Hello, everyone, and welcome to the Managing Mental Health Issues in the Workplace, an Integrated Approach webinar with Dr. Richard Wynne. This webinar is part of our Return to Work, Stay at Work series, and we're glad to have you all here with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability. This webinar is made possible through the support of the Community Grants Program and through the BC Government, as well as through donations and memberships to our organization. As I mentioned, my name is Tanya, and I'm moderating the session and handling the Q&A today. And our speaker is Dr. Richard Wynne. Dr. Wynne is Director of the Work Research Centre, a Dublin-based independent research and training organization. Dr. Wynne has worked in the area of workplace health promotion for more than 20 years, and in recent times he has taken a special interest in workplace-based mental health promotion. He has worked and led many transnational projects in the area, including Reintegrate, Pro-Men-Pol, Mind Health, and MHP handbooks. He also lectures at the University College of Dublin. And I will hand it over to you now, Richard.
Thank you, Tanya, and greetings to you all from Dublin. It's a warm, dark, wet evening here, and I hope it's better for you wherever you're listening in from. I want to talk to you today about managing mental health issues in the workplace, an integrated approach, which is based on work that we've been doing over the last number of years and which has culminated in some work we did for what is called DG Employment, which is an arm of the European Commission, where they have asked us and various other organisations to contribute to producing a guide for employers about how do you manage mental health issues in the workplace. So I'm going to take you through some of the reasoning behind that and some of the detail of that here this afternoon, or what is this afternoon for me at least. As Tanya has said, I am an independent director of the Work Research Centre, a research and training organisation which has been on the go since 1988. We have done many research and development projects over the years in relation to workplace health, mainly in a European context, so that we would tend to do this work in collaboration with partners in could be 4 or 5 or 6 or as many as 20 odd European Union member states. So I think what I'm talking to you about here today is coming from a pan-European view rather than a specifically Irish view. What I would like to talk to you about is that firstly about how mental health issues impact on the workplace, because I know that from talking to Tanya that you come from a range of different backgrounds, and I just want to sketch out what it is that we feel mental health issues are and how they might impact in the workplace so that we're all starting from the same kind of place. I want to talk about the nature of workplace mental health and well-being, and particularly I want to talk about 3 different approaches to the management of mental health and well-being at work. One is the whole issue of mental health promotion, which is broadly speaking coming from a public health tradition and being applied to the workplace. The second is the health and safety tradition, which in recent years and decades has been becoming increasingly concerned with issues of occupational stress and its effects on mental health. I'm fully aware, of course, that occupational stress is not equal to mental health, but there is a relationship between the two. And the third issue which I want to talk to you about is the issue of return to work following some kind of mental health issue that somebody might have. This is relatively recent concern in Europe, but I know that there's been some sterling work done in Canada over the last number of years in relation to codifying how you actually manage return to work for people with all sorts of health conditions. I want to talk to you about the importance of an integrated approach. In other words, in dealing with all 3 elements of the approaches that you might take rather than just one. One of the curses, for want of a better word, of what goes on in Europe a lot of the time is that people tend to work in silos. So, for example, the health promotion people don't necessarily talk to the occupational health people, who don't necessarily talk to the people who are involved in case management and return to work. And very often, if there is a dialogue at all, it can be the dialogue of the deaf. And what I would like to do is to emphasize why we need to have some kind of integrated approach. Lastly, I just want to point you in the direction of, I'm not going to have the time to go into any detail on it, of how Europeans and some others are approaching the issue of mental health in the workplace. There have been some significant issues and approaches developed over the last while, the last decade in particular in Europe. And if I can just point you in the direction of them, for those of you who are interested, you may be able to follow them up in your own time later on. So what is mental health and how does it relate to the workplace? Broadly speaking, I think there are four issues which we need to be looking at, and they are distinct because they tend to involve different kinds of interventions or indeed non-interventions. The first is mental well-being, in other words, the process of being well. One of the problems with occupational health approaches is that it tends to assume that work is bad for your health, whereas we know from most of the statistics that on the average, work or people who are in work and are in employment are in better health, both physically and mentally, than people who are out of work, be it due to unemployment or disability or whatever it happens to be. And when we're talking about mental well-being, we need to consider what aspects of work and jobs actually contribute to improved and positive mental well-being. Another element that I think we need to look at is the issue of disturbed mood, and this is, for want of a better word, non-clinical impacts on mental health, where you have low mental well-being, where you might have some symptoms of depression or anxiety or whatever it happens to be, but it's not diagnosable as a clinical condition. And this is also of concern. Then we have the two, and I forgive the terminology here, major sort of classes of mental illness. That is non-psychotic disorders and psychotic disorders. And both of these tend to have different approaches attached to them as well. So these are the kinds of phenomena, mental health phenomena, that I want to include in the pot as we talk about an integrated approach to mental health in the workplace. You may be familiar with this diagram. It views mental health as not as a single continuum, but as a bidimensional phenomenon where you've got, for example, a continuum between mental illness and mental health or well-being, and between flourishing and languishing. In other words, where you are more active or more passive in relation to your mental health. And you can see for yourself some of the kinds of feelings and behaviours that we might be associated with each of these different conditions in each of the four quadrants. The point about this is that if you are making interventions for mental health in the workplace, I think we are often looking at specific interventions for each of these four quadrants, rather than just talking about some amorphous intervention which might address mental health. Let me give you some data on prevalence and cost from different parts of Europe, because I think I know that Canada has quite a lot of data in this area, but I just want to put some figures on it from a European perspective, which I think begins to explain why countries and indeed the European Commission are starting to take the issue much more seriously. From the World Health Organization, we know that around about 25% of people will have a mental health problem during their lifetime. And in any 1 year, around about 9% of people experience depression, and about 2.6% experience a psychotic disorder. Now, of course, not all of these are in work or in employment. Some of them will be retired, some of them will not be of working age. But the general point about this is that it's something which affects most or many people, and if we don't be affected by it ourselves, we certainly know of people who are affected by mental health problems. I hope your German is good, but this is something which talks about mental health and its effects on absenteeism over time between the years 1997 and 2012 in the German Federal Republic. And the key point about this here is that if you look at the brown line, which is the bottom of the two lines, this is absenteeism due to all causes, and you can see that it's a more or less flat line, taking 1997 as 100 as the baseline, although it has gone up a little. But there has been a spectacular increase in absenteeism due to mental health issues since 1997 up as far as 2012. In fact, there's 265% of the 1997 level. This data is taken from the German, one of the German sickness insurance funds, DAK, and there are a number of these in Germany, and all of the data from all of these will show more or less the same kind of pattern. So it's contributing more and more to absenteeism, and in fact it's probably contributing all of the increase of absenteeism that's occurring in Germany. This is data from Sweden, from the Swedish Social Insurance Authority from 2013, both for women and men, where they're looking at the issue of new claims for early retirement and disability. And here what we're talking about is, again, an increase in the causes of these claims for early retirement and disability from psychological conditions and indeed conditions of the nervous system. At the bottom of the diagram, in both diagrams, you can see that if you take the women as an example, that in 2003, new claims due to psychological conditions are around about 30%, and they are now in 2012 much closer to 40%. Similar figures are the situation for men. Just above that in the pale line, you can see the conditions of the nervous system. They have also increased somewhat over that period. Now, without wishing to labour the point, I think it's fair to say that across certainly the European countries that collect good data, this is a common phenomenon. We are seeing increases in claims for disability, increases as a cause of absenteeism due to mental health conditions of one sort or another. A number of years ago, we did a 6-country study in, if I remember the countries correctly, Austria, Finland, the UK, Ireland, Italy, and the Netherlands, on the issue of stress and stress-related conditions and how it impacts on absence. And at that time, this was about 10 years ago, it was the commonplace perception that the biggest causes of absence were in fact due to musculoskeletal problems. But we found that across all of the 6 countries that took part in the study, that in fact mental health problems and indeed comorbidity due to mental health problems and physical health problems were the biggest single cause of absence. And these were people who had been absent for at least 6 weeks from work, and they were on the short-term sickness registries. They were on social welfare. When we looked at the actual causes of these mental health disorders and absence, the biggest single contributor, contributing about half of the volume of people, were people with depressive disorders. All of the rest of them were around about 10% or less, which included anxiety disorders, alcoholism, drug abuse, and so on. And this Irish data, I just give you this because it's stuff that we have collected over a period of more than 20 years from a range of different occupational groups using a measure some of you may be familiar with, which is called the General Health Questionnaire, and which measures poor psychological well-being. And these are the percentages of these different groups that have got poor psychological well-being. The point about this is that it's not necessarily the clinical mental health or diagnosable mental illness, but it is something which is causing people problems and from which they would benefit from an intervention. And you can see from this that the biggest single group are the ones with the highest levels of mental health or mental well-being problems were people who were unemployed. Around about 60% of these had disturbed psychological well-being. And these were closely followed by a group of nurses who were working night shifts, where almost 50% of them had some kind of poor psychological well-being. Airline cabin crew in 1995 and indeed in 2014 again were very, very high. People who were ill or disabled were very, very high. And you can see the other groups there for yourself. The point of showing this graph is not so much to boast about how many Irish people have poor psychological well-being, but to make the point that different occupations tend to have different levels of psychological well-being associated with them. The point here being that different occupations carry with them different loads of stress and other issues which are contributing to poor psychological well-being. Now, this has implications, there are obvious implications for health and safety practice, but it also has implications for return to work practice, where if, for example, you know that you are returning nurses to night work, it's quite a different proposition than if you're returning nurses to work which is not involving night work. So if you see, for example, the differences between general nurses and night nurses is around about 50% to 30% or so. So it is something which is to be borne in mind. Not all occupations are the same, either in terms of the demands that they create in people, or indeed in terms of the receptivity to return to work. There are costs, there are substantial costs, and in recent years there has been some serious attempts to estimate the economic costs of mental health issues in Europe. These are this particular diagram is taken from some work which was done by the European Union's Occupational Safety and Health Institute in Bilbao, where they estimated this is the overall cost of mental health problems, or indeed what are called brain disorders in Europe, in public health terms, and they estimate that at around about 797, or let's say 800 billion in the year 2010. Bearing in mind that the population of the European Union is around about 500 million, so you can possibly do the figures yourself if you can prorate it to the Canadian situation. The general point is that it's a serious amount of money, and it has woken up the authorities, both public health authorities and occupational health authorities, that there is something maybe that they need to do. One of the responses of the European Union was to create an initiative called the Mental Health Pact, which also undertook some estimate of the costs of mental health problems, but particularly looking at the workplace. And they were only looking at the productivity costs here, so they weren't looking at treatment costs, they weren't looking at opportunity costs, they weren't looking at reintegration costs or anything like that. They were just solely looking at the issue of productivity and lost labour days in effect. And what they found was that the total productivity cost of mental health disorders in what was then the 25 member state European Union plus Norway, Iceland and Switzerland was estimated to be 136 billion in 2007 prices. Around about 100 billion of this was linked to depression and anxiety related disorders. And I think what is most striking about this is that when you look at the equivalent productivity losses for cardiovascular disease, which is generally speaking a much bigger concern for public health, they were only about 36 billion. In other words, roughly speaking, mental health problems are costing the workplace around about 3 times as much as cardiovascular disease is. It also pointed to the issue of presenteeism, in other words, the phenomenon whereby people come to work while not well, or if not being actually ill. And this impacts on productivity in a negative way also. And various estimates from European studies would place the excess of the costs on productivity at between 50% and 500%. So that this figure of 136 billion, if you take into account presenteeism, could easily be doubled or more in the European context at least. Okay, that's some of the standard kind of public health statistics that you might see, and indeed occupational health statistics that you might see. And I want to actually start to focus on the issue of the workplace itself a little bit more. One of the problems workplaces face in dealing with this is that, as I say, they take a unidimensional view or a single perspective view of what's actually going on when it comes to mental health. So, for example, many employers might say that mental health is only an issue for me and to the extent that I have to control occupational stress in the workplace. Public health physicians might say, well, they have no concern about workplace at all. They're really only concerned about helping their patients to get better. Others may point to the fact that various manifestations of mental health issues in the workplace are not really the responsibility of employers or indeed of occupational physicians or indeed any of the other stakeholders or players within the workplace. What you've actually got, though, is a situation where the impacts of mental health, regardless of cause, are creating problems for workplaces in terms of such issues as productivity, in terms of such issues as quality, in terms of such issues as output, in terms of such issues as planning and so on. This diagram is an attempt to put together the fact that really when it comes to the individual, the workplace, and indeed extra workplace factors, the workplace is just a forum in which all of these things interact to produce mental health problems which will impact, regardless of cause, on how the workplace functions. So for example, things like genetics and previous life experience and life events are important from the individual point of view in terms of impacting on their mental health. Whereas in the workplace, we know, for example, that poor communications is a major cause of stress, that bullying, sometimes called mobbing in Europe, and violence in the workplace is a serious issue and has major impacts on mental health. We shouldn't forget that toxins in the workplace can issue on mental health as well, something which is often forgotten by people from a psychological tradition, like me, for example. You've got issues such as poor work organization and poor job design contributing to mental health problems. And the effects that you see are some of the ones that we talked about already. You're talking about effects on mood, you're seeing anxiety, you're seeing depression, you're seeing breakdown of coping skills, you're seeing burnout, and you might also see mental illness from the point of view of the individual. And from the point of view of the workplace, you're looking at effects on productivity, absenteeism, presenteeism, morale, reputation, and so on. We have proposed an integrated approach to dealing with these manifestations of mental health issues in the workplace, and we're calling it, for want of a better word, integrated workplace health management. It could be mental health management, but I think it also extends to physical health management as well. And you're looking at the three broad traditions of intervention in workplace to improve health or to maintain health. The oldest of these is the issue of prevention and health and safety, which goes back into the 1800s in terms of physical health risks in the workplace, but goes back into the 1970s and 1980s in Europe, at least, in relation to dealing with occupational stress in the workplace. A second element, and which is much more recent, and I think which you're probably very familiar with in Canada, is the issue of health promotion in the workplace. You could argue it started out initially in 1974 in Canada with the Lalonde report, but we won't go into that now. But the general point about it is it's the bringing in together of public health approaches to dealing with mental health. In other words, it's about the maintenance of mental health and the promotion of well-being. Not so much about the prevention of breakdown. And then we've got the issue of return to work, as when mental health breaks down, how do we get people back to work? I think it's worthwhile considering when looking at this diagram. It's easy to draw three lines that fit neatly into the middle of the diagram where you've got integrated workplace health management. But the problem very often in practice is that you've got different people, different skills, different professions, different levels of knowledge, plus non-professionals who are involved in the whole business. And that is where many of the problems actually come from in terms of implementing something like this model. And I'll talk a little bit more about that as we go along. The general consideration that we had in developing these guidelines for employers in Europe about workplace mental health management was that we know that there are these three approaches to dealing with health in the workplace, which is OSH, mental health promotion and rehabilitation and return to work. But that, as I said earlier, there tends to have been a silo approach in Europe whereby the people in the professions and indeed the employers have tended to keep these traditions or these types of interventions separate, and they don't see them as being terribly linked. But the realization we came to was that if you look at what actually happens when these things take place in the workplace, you'll find that there are a lot of common methods between the three different approaches. Of course, there are specific methods which are only used by one or other of the approaches as well, but that you'll tend to get shared outcomes or common outcomes as well, both in terms of organizational impacts and individual impacts. So, for example, reducing occupational stress and training people to do their job properly can contribute to the same kinds of outcomes as mental health promotion interventions, such as improving the resilience of the person or improving their coping skills, for example. The point being here that if you are an employer, it perhaps doesn't matter so much what tradition these interventions come from if you can produce the levels of outcomes, desired outcomes in terms of organisation and individuals using some combination of all of these. I hope you can see this, but I'll be talking a little bit more about it in detail. There's a couple of more slides to come about it. This was our attempt in the employer's guidance to produce a diagram outlining what we meant by a common approach to workplace mental health management. And you can see the three traditions in the three columns on the right-hand side, where you've got occupational safety and health, mental health promotion, and rehabilitation and return to work. And on the left-hand side, you've got three kind of stages, for want of a better word, where you've got initially you've got the issue of information gathering and analysis of information. Secondly, you've got a set of interventions and different methods and activities that might be undertaken. And thirdly, you've got a set of outcomes which might be achieved by undertaking these various interventions. Within occupational safety and health, information gathering is largely about hazard identification and risk analysis. It may also be about infrastructure assessment, in other words, seeing what can be done in terms of physical infrastructure and indeed organizational infrastructure to identify what problems might be. In mental health promotion, you're not so much looking at hazard identification, but you're looking at needs analysis. What do people need? Ask them what do they want to do to improve their mental health. And again, you might be looking at some infrastructure assessment here. Whereas if you look at the information gathering needed for rehabilitation and return to work, it tends to be a little bit different. You're talking about analysis of absence data. You're talking about looking at what kinds of rehabilitation might be needed. But there is also a needs assessment which takes place here. When you look at the interventions that might be undertaken, there's a lot of commonality, particularly between occupational safety and health and mental health promotion. So, for example, you might be targeting the physical work environment. You might be targeting the psychosocial work environment in terms of work organization and job design. You might be looking to boost people's knowledge of what the hazards are in the workplace, or indeed what might be done to improve mental health in the case of mental health promotion. So education and training are important. You might be looking at cultural change and behavioral change. Now, in the case of rehabilitation and return to work, there's some fairly distinctive interventions which might be made, particularly around the issue of case management and rehabilitation, which are not normally part of the other two traditions. But when it comes to beyond, once you've started to assess the capacity of the individual to go back to work, the kinds of interventions you're making at the physical environment and the education of the individual and co-workers and work organization and job design and so on are quite common to what might be done in health and safety or indeed mental health promotion. You would expect, well, yes, indeed.
Sorry to interrupt. You wanted a 15-minute warning? It's about 15 minutes out.
Okay, thank you for that, Tanya. Yes, just to say that the outcomes that you might get are often shared. So we're looking at things like reduced accidents, reduced occupational illness, lower stress, better work practices, better quality work, better health, and so on. In other words, common interventions from different traditions producing shared outcomes. And that is the basis for what we were talking about. We're looking at this integrated mental health management approach here in Europe. So I want to go into a little bit more detail about some of the issues here, about what is workplace mental health promotion, and indeed some of the other interventions as well. I think there are four main elements. I mean, it depends how we look at this. I mean, and I'm not too hung up on definitions and what fits under what heading, but I think these are the kinds of things which need to take place, or however you define them. Firstly, you're looking at promoting mental health at work. Secondly, you're looking at prevention of harm to mental health, and this is quite different to promoting mental health at work. Remember, OSH is probably the only part of the whole affair that is actually legislated for, unlike the other two elements of return to work and promoting mental health at work. You're looking at the treatment of mental health problems, and this is very much in the case of developing links between mental health promotion programs and treatment services. You could argue this is basically case management, and it can be about rehabilitation of employees with mental health problems. And here we're talking about having effective return to work procedures, which are surprisingly uncommon across many different countries, as I'll show you in a moment. If you look at mental health management interventions, the traditional approach is to actually deal with occupational stress, and there are many good hazard identification and risk management approaches, which I'm sure you're aware of. In fact, the Canadian approach on standards for occupational stress is having quite an impact. Whatever about in Canada, in some countries in Europe, it's been applied quite vigorously at the moment. So the kinds of hazards that you might be looking at would be things to do with job content, workload and work pace, work schedule, the control that people have over their work, the environment and the equipment that they use, the way that the organization functions and its culture, interpersonal relationships, and so on. This is a characterization of stress in the workplace which is commonly used here in Europe, developed in the University of Nottingham. This is often put within the framework model for the management of psychosocial risks. This has been adopted by the European Agency for Occupational Safety and Health. And it talks about a risk management process taking place within an overall production process within an organization, and including risk management and audit, the translation of risks into action plans and their implementation, the evaluation of whether these things have worked or not, and that there is some level of organizational learning so that you've set up a virtuous cycle to produce positive outcomes. And I've mentioned some of these already, so I'll move along to the next slide. But basically, you've got common interventions which can happen across the three different areas that I've been talking about. I want to talk a little bit about return to work here, because it's something which I think is probably of major concern to you all, and I want to give you some European experiences on this issue here as well. In the stress impact study we did, we had a look at the numbers of people who actually returned to work following 6 months absence of work from work, and to see what was actually happening to them. And here you see the diagram where you've got 5 of the countries: Austria, Finland, Ireland, the Netherlands and the UK, and people who have returned partially to work, which is brown on my screen, it's the left-hand bar, and people who have returned fully to work, which is blue on my screen. And you can see that 2 or 3 things there. The first thing that strikes you is that there are massive national differences between countries. In particular, the Netherlands is getting far more people back to work than just about the rest of the countries combined. And also that there are big differences between people who return to work partially and fully. And partial return to work is much more common, except in the UK, strangely enough, and I don't have an explanation for this, than in the other countries. But the massive point about this is that between partial and full return to work, fully 70% of Dutch people are gone back to work 6 months after absence. And you can compare that to Finland or Austria, where only about 25% have. So the question must be, what are they doing in the Netherlands that is different? What they've tended to do in the Netherlands is they've tended to look at things in terms of a threshold. In other words, that when people develop some kind of illness, they face what is called the absence threshold. And the simplest way to think about a threshold is think about what is it that makes you say on a Monday morning, I am not going into work today, I'm too sick. And that is the assessment of all of the factors which contribute you to making this decision not to go to work. That is the absence threshold. And it comes from factors which relate to yourself as a worker. It includes work and non-work factors. It includes the availability or non-availability of services. And it takes place within the context of legislation, policy and regulation at national or local level. Anyway, if you go absent, there is also a return to work or reintegration threshold. And again, the same kinds of factors, or classes of factors, might influence the decision about whether you come back to work. It's about you as an individual. It's about work and non-work issues that you might face into. It's about the services that might help you to get back to work. And it's about the general policy context here. The point is that when you go back to work, you've got, roughly speaking, 3 things which can happen. You can return to work in the same job, You can be redeployed within the same company or employer, or you can be redeployed to another company. You can also, if you don't return to work, become either unemployed or economically inactive. And as you can see from the previous diagrams, far too many people do become unemployed or economically inactive in many of the European countries. We studied what were the factors which actually operated at both the absence and the return to work thresholds in these 5 countries, and we came up with a list of issues which I think, some of which at least are quite interesting. The things which contributed to being more likely to go absent from work were things like poor health, having had some traumatic injury, or having had some significant event, such as a major life event or indeed a major work event, which has contributed to you going absent. The things which led people to be less likely to go absent were having a low income. In other words, people couldn't afford to go absent. Where people had premeditated, in other words, they thought about going absent for often a long period before going absent, but if they thought about it, they were less likely to go. If they had family responsibilities, if they were in more senior roles within the organization, these were people who were less likely to go absent. However, when they had gone absent, we looked at the factors which impacted their decision to go back to work, and these were different. They're not the same factors necessarily which led you to become absent in the first place. So, for example, an increased likelihood of return to work was, and I just highlighted some of these here, not for any particular reason, but just to say that these, I think, are important issues. Some of the factors here really relate to what it is that the workplace does and how active the workplace is in terms of getting people back to work. So if your workplace has a formal return to work system, in other words, if there's a proper case management system in place, you're more likely to go back to work. If you had a need or a desire to return to work, this was more likely to help you to get back to work. If you wanted to maintain your mental health, in other words, being absent from work was often damaging to people's mental health. We found over time, for example, that if people went absent for a physical health reason and were absent for long enough, they would often develop a mental health problem as well. So getting back to work can help maintain mental health. If you had good workplace support and practical help, it got you back to work earlier. And if there were good communications between the workplace and the absentee. If you look at the things which reduce the likelihood of people to come back to work, you're talking about factors such as workload being too high, no real level of accommodations, workplace accommodations to get people back, poor mental health, in other words, there hasn't been an improvement in your mental health, and if there has been a failure to rectify negative conditions in the workplace which might have contributed to you going absent in the first place. I just point you to this. You can find some detail on it and have it explained to you in one of the websites which I'm going to give you at the end here. This is an intervention framework for back to work, and really the point is that if you want to assess the return to work threshold, you've got to look at personal factors, work factors, non-work factors, and different system factors, which will help you to generate a targeted back to work intervention plan, which is much more likely to be successful than something which is non-specific. In practical terms, there's a couple of things I want to point to which help or hinder the issue of not just return to work, but of the whole issue of integrated workplace health management. So there are a number of problems faced in moving from sort of the theory of what I've been talking about to the practice of it. And the first one is that the role of the integrated workplace health manager is different to that of the traditional professional role. The relationship between the health promoter and the client is different to most other settings. It's not a nurse-patient or a teacher-pupil type of relationship, nor is it a relationship between an expert and a novice. In effect, because a lot of this is voluntary, you're looking at being a persuader rather than somebody who orders things to happen. So you need to work through others and you need to influence target groups. A second point is that it's a socio-technical approach that's needed. In other words, that you need to take into account not just the methods and tools that you have at your disposal to support mental health promotion, but you need also to look at the social situation within a given workplace and tailor your interventions to that social situation. It's difficult to get support. but it's a key aspect in doing this in a comprehensive way. It's difficult to structure an initiative very often because people are reluctant to commit to very large-scale projects very often. But an achievable project plan is a serious and good way to actually start to integrate or to deliver integrated workplace health management or mental health management. And lastly, communications. Communications are a serious issue here, and none of these things will happen unless you have good communications practice with all of the stakeholders concerned. Very briefly about the benefits of action, there's been some good evidence collected in Europe about how even modest improvements in workplaces can have a substantial economic impact. So there's a good business case for doing this. This is some work which was done in relation in the UK in particular, looking at the net return on investment for different kinds of public health interventions, and we've circled 3 of them here just to point out that these things can be very beneficial. The first one is that if you look at early diagnosis and treatment of depression at work, roughly speaking, you get a 5-fold return on the investment that you make there. If you do screening for alcohol misuse, you get almost a 12-fold return on your investment. And at the bottom one there, if you look at the workplace health promotion programs, have around about a 10-fold net return on investment. This is from the point of view of the public health system, not necessarily from the employer. But if you look at the employers, and this is some work that was done for the European Commission in 2012, you can see that you just need to look at the bottom line here. The overall cost-benefit ratio of different kinds of interventions are again very, very positive, although they're quite different from one type of treatment or intervention to another. So workplace improvements were very, very effective, and almost a 12-fold return on investment. And you can see the rest for yourself as well. The general point is that there is a strong case both at workplace level and at health system level for engaging in these kinds of interventions. Just want to point to the fact that countries in Europe, and you can find out more about this in the guidance that we've developed for the European Commission, are really quite active in the area. This is just a selection of some of them. So in Belgium, for example, they're involved in the prevention of psychosocial load. There's a major initiative in this, which is caused by work. In the UK, they've got management standards for work-related stress, which are directly taken from the Canadian experience here. In Italy, they've also drawn on the Canadian experience in developing their management standards for health and safety management. Scotland, which I always think is an interesting place for all sorts of reasons, have a policy called towards a mentally flourishing Scotland, and it's possibly the only country in Europe which talks about mentally flourishing as opposed to preventing mental illness. And this has found its expression into the workplace as well. And you can see some of the other initiatives down through the list here. You can find out more from some of the references I'm going to leave you with here now. Some resources you may care to look up include the first one, which is the European Agency for Occupational Safety and Health. I have lots of material in this area. The second one is an organisation I'm a member of myself, which is the European Network for Workplace Health Promotion, and this has many materials and case studies and the like dealing with mental health promotion. The third one is mentalhealthpromotion.net, which is looking particularly at mental health in the workplace, but also in some other settings. The stress impact materials are to be found on the fourth website here. And lastly, promoting mental health in the workplace guidance for implementing a comprehensive approach is the work that we have done for the European Commission in DG Employment. Many thanks for your attention. I think I'm more or less on the button time-wise. I hope this was of interest to you, and I'm more than happy to answer any questions that I can now. Thank you.
Great. Thank you very much, Richard. That was a very good presentation. It's always so interesting to see and get expert opinions on things that people are doing in other parts of the world, because it can be so easy to just kind of focus on what's Canada doing or what's even my local province doing. So it's a really great perspective to offer to the conversation.
Thank you.
Let's see, a couple of questions. So one question is, back on the slide where you were talking about psychological well-being, it was a little bit closer to the beginning, and there were
Yeah,
selected Irish groups, and there
yeah,
were 2 bars for the unemployed.
yeah.
Someone's wondering, what is the difference in the groups there?
There were two different samples. One was a group of young people who were unemployed, and these were the higher of the two. They were basically young unemployed who had not yet got their first jobs. And the second was a group of people who were drawn from the unemployment register who were of all ages, most of whom would have worked before, and these were less affected.
All right. And then do you think that there has been an increase in mental health diagnosis due to the fact that general practitioners are loosely using the term depression/anxiety to provide a diagnosis without having the proper training or measuring tools, and that GPs have a tendency to label employees with mental health conditions rather than just everyday life stressors and workplace issues?
I think that's a very complex question, and I think there's a lot going on which your questioner is obviously aware of. I think there are two or three things going on. I think firstly, there has been a reduction in the taboos associated with mental health issues, and more generally in society, people are more willing to talk about mental health and mental well-being issues, however well or ill-informed they are about what they might be actually talking about. I think the same thing applies to GPs in particular, where they don't tend to have very strong training in mental health. I mean, I was talking to one recently here, and he said he had 6 weeks training in mental health, so he knows almost nothing about it, and this is over the course of a lifetime. I'm sure he's not atypical in this. On the other hand, they do provide this as a diagnosis more often, I think mainly because people are almost demanding it of them. And they're in some cases only dimly aware of what it is that they're actually dealing with. But I would say, yes, there's been a tendency to have increased levels of diagnosis, which is probably reflecting reality. Because I think most of what we saw before, particularly all of the musculoskeletal problems that we saw before as a cause of absence from work, were leading to a serious underestimation of what the true impact of mental health issues might be.
All right. And then what do you think about ergonomic intervention in improving mental health in the workplace? Did the job occupation and requirements have been assessed according to an ergonomic approach, or were only reported or provided by the employer? And knowing the real activity of work by observing workers could highlight cognitive charges and stresses that have not been communicated by the job description provided by the employer.
If I understand this question directly, or properly, I think the person is asking about, is ergonomic assessment based on employer reports sufficient to get a good knowledge of what it is that the person is actually doing or returning to? I would answer no, it's not good enough. I think you do need observations as well. I mean, I think ergonomic interventions have to be honest, quite a limited role in terms of improving environment from the point of view of mental health. I think what's far more important are issues such as organizational structure and culture and job design and work organization. And these are the areas which we need to be focusing on if we want to return people to work effectively who have either mental health problems, or you want to make the workplace more, on the one hand, receptive to people returning to work, but also more salutogenic. I apologize for the phrase. In other words, more health-making. When I talk to my students, one of the first questions I ask them is, how do you make health? And if you think about the workplace, the question here is, how do you make work, what aspects of work actually make health? And it's more than just physical ergonomics. It's often about monitoring and developing the psychosocial work environment as well.
Next question is, have you come across research or conducted some that indicates that having a diverse managerial team, one that includes an understanding of mental health, works to improve workplace mental health, and wondering how helpful coaching as an intervention would be?
I think The first point is that management teams who have a higher level of awareness of issues of mental health and well-being, and indeed the contribution that workplaces that can contribute to it, tend to do better. There is research being published in that area which shows that the more aware and the more diverse the approach that organizations have, the better they tend to be at dealing with this issue. I actually had a slide which I don't have in front of me at the moment, which I intended to use or didn't have time to show you, but I can send it on to you as part of this, which will demonstrate some of that research. When you consider that, as somebody once said to me about the issue of disability, that most employers approach it with a mixture of fear and ignorance, I think that's true often of mental health as well. And if that is the typical approach of an employer, they can't be good at managing mental well-being. Now, coaching is one of just a number of interventions that might be made to improve, for want of a better word, organizational culture in relation to the issue of mental health. It certainly helps to raise awareness. It certainly helps to give people some skills. It certainly helps to boost the capacity of an organization to actually deal with these issues, but it's not the only one that can be done. I think strong policy is important as well. I think strong practice is important. It's not just about what the individual does, but it's about the whole overall organizational philosophy as well.
Wonderful. That is the last question that I have on here. I might give just another moment just in case anybody else has any final questions.
To say everybody understood everything, yeah?
It seems like they did, yes.
Yeah.
Seems like we probably don't have any further questions. So I'm going to go ahead and wrap it up. Thank you very much, Richard, for the presentation and for your insight and knowledge on this topic. It's very interesting.
Well, thank you, Tanya, and good day to you all over in Canada.